Bismillahirrahmanirrahim. This is the remaining portion of the chapter anticoagulation. So today we will discuss about the treatment of venous thromboembolism. Actually, venous thromboembolism, we will see the pathophysiology a little bit. There is a virtue triad. Virtue triad have different components like venous stasis, vascular damage, inherited or acquired hypercoagulable states. When these three components combine, they cause the like venous thromboembolism. And some patient has carrying high risk. That patient has a previous VT, cancer, orthopedic surgery. They are carrying high risk. How we diagnose the DVT? First of all, there is a well criteria that is used for the DVT and also the PE. That criteria actually give us the probability of patient having the DVT. If the patient has a low probability, low test probability, and the patient is younger than 65 year and the patient has negative D dimer value, so we exclude the DVT. On the otherwise, we will continue with we confirm the DVT with the ultrasonography or different imaging studies. This is the Wells criteria. It's have different components: active and cancer, paralysis, recently bedridden patient more than 3 days, localized tenderness, entire leg. Each factor has 1 point. If the patient has the score is less than 0, it's a low chance, low risk patient. If it's between 1 or 2, that is a moderate. More than 3 is a high risk. Next, similarly, PE, we determine the p-test probability with the Wells criteria. And this here the different factors for the Wells criteria is cancer, hemoptysis, previous PE, DVT, heart rate, recent surgery. Each factor had different points. We calculate the points and we calculate the risk stratification for each patient, like 0 to 1 is a low, 2 to 6 is a moderate, more than 7 or equal to 7 is a high. Next is the treatment strategy. There are three different treatment strategies for these patients. First is the bridging therapy. In the bridging therapy, we start the anticoagulant, injectable anticoagulation and warfarin together, and after 5 days when the INR is within the therapeutic range, we stop the anticoagulation, injectable anticoagulation, and continue with the warfarin. In changing therapy, we start with the injectable, and after 5 days we discontinue the injectable and start with the Debicatron and doxaban. In the monotherapy, we initiated with the rivaroxaban or bixaban higher doses, and then we change the dose with the gradually and decrease the doses. So in that case, in the monotherapy, we use single drugs, start with the higher dose and gradually we decrease the dose. Bridging therapy, as I told you, that warfarin is bridged with the injectable anticoagulation, and after that when the INR is within the therapeutic range for warfarin, we stop the injectable anticoagulation and continue with the warfarin. The INR goal is 2 to 3 in that patient. Lower INR goal is not effective. Which patient category we use this therapy? The patient cannot use the direct oral anticoagulation as the creatinine clearance is less than 30. Patient cannot afford the direct oral anticoagulation therapy, or patient when transition from inpatient to outpatient, they cannot acquire the direct oral anticoagulation. So in that cases, we are recommended this type of therapy. Different dosage strategies for the injectable anticoagulation in this therapy are like IV. We start with the 80 units per kg of the initial bolus dose, then continuous infusion with the 18 units per kg per hour. If we use the subcutaneous, we have two options: either we are using 250 units per kg every 12 hour, or the other one is the we start with the bolus of 3 units per kg and then continues with the 250 units every 12 hour. If we use the enoxaparin, we will start with the 1 mg per kg every 12 hour or 1.5 mg per kg every 24 hour. If the creatinine clearance is less than 30, We will continue with the 1 mg per kg every 24 hours. Deltaprane, either we are using 100 units every 12 hours or 200 units 24 hours. For Fondaparinux, we use the weight-based dosing, like if a patient is less than 50 kg, give 5 mg every 24 hours, 50 to 100, 75, more than 100 is 10 milligram per every 24 hours. If the creatine clearance is less than 30, the Fondaparinux is not indicated. The other is the changing therapy. In changing therapy, we start with the injectable anticoagulation. After 5 days, we stop the injectable one and start with the direct oral anticoagulation like Debicatron or Rituximab. In the Debicatron trials, there are two trials, Recover 1 and Recover 2 for the DVT and PE. They are compared with the standard therapy. In the active group, the patient start with the injectable anticoagulation, and for the median of 9 days they continue the injectable anticoagulation, then they stop the injectable and start with the Debicatron. On the control side, we use the standard therapy, like we use the bridging therapy, warfarin combined with the injectable anticoagulation, continue for 5 days, then stop the injectable and continue with the warfarin. Sorry. The primary endpoints like VTE, symptomatic VTE events are same between the two groups, but the major bleeding was significantly reduced with the Debicatron. Similarly, the major bleeding and critically relevant non-major bleeding was significantly reduced with the Debicatron groups. The other trial is with the Doxaban trial. This is also the similar trial. In the initially they in the active group, they start the injectable anticoagulation for up to 7 days. They use the injectable anticoagulation, and then they stop the injectable anticoagulation and continue with the edoxaban. For the other hand, the control group, they use the warfarin standard therapy. They start warfarin and anticoagulation, injectable anticoagulation, continue for 5 days, then stop the injectable anticoagulation and then continue with the warfarin. Similarly, the primary endpoint, symptomatic VTE events are same, but the major bleeding also in this trial, the major bleeding was also not significantly reduced with the edoxaban. But if you combine with the major bleeding and clinically relevant non-major bleeding, then it is reduced in the edoxaban group as compared to the warfarin group. Next is the monotherapy. Monotherapy, as I told you, that they start with the initially high dose, then gradually decrease with the doses. In the rivaroxaban, Einstein DVT and Einstein PE trials, they started the rivaroxaban and compared with the enoxaparin in the control group. Enoxaparin 1 milligram every 12 hours they used. In the if you will in this trial, you will see that the some patient they treated for 3 months, some for 6 months, some for 12 months. But both the trial DVT for PE, Einstein PE and Einstein DVT, 73% in DVT trial and 93% PE trial, the patients who started the rivaroxaban, they were already using the injectable anticoagulation before. Similarly, the primary endpoint, symptomatic VTE events, are similar in both the standard and the control therapy, but the major bleeding was reduced for like 46% reduced major bleeding with the rivaroxaban. Major bleeding and clinically relevant non-major bleeding did not have any difference in both the group. Next is the ABIGAIL trial. ABIGAIL trial is similar to the rivaroxaban. They started the ABIGAIL at higher dose and compare with the enoxaparin. The here also 86% patient in the ABIGAIL groups, they were already using the injectable anticoagulation. Here similarly, the primary endpoint, there is no difference, but the major bleeding was reduced with the apixaban. Here the 70% reduction, and also the clinically relevant non-major bleeding was reduced in the apixaban group. These are the different dosage strategies which they used in different trials. Debicatron, as we know that Debicatron is using as a changing therapy. So they use the Debicatron 150 mg twice daily for 5 to 10 days. And idoxaban is also used in the changing therapy. So it's started with they use 60 milligram once daily for 5 to 10 days of the injectable anticoagulation. Rivaroxaban and bixaban, they are used as a monotherapy. Rivaroxaban, they started with the 15 milligram twice daily for 21 days, then 20 milligram once daily for 6 months, then they reduced to 10 milligram once daily. Similarly, bixaban 10 milligram twice daily for 7 days, 5 milligram twice daily for 6 months, they reduced to 2.5 milligram twice daily. And also they use the adjusted doses with the different condition, like if the patient has the different clearance values and the patient were using the strong inhibitor or inducer of cytochrome P50, so they adjust the dose accordingly. Secondly, prophylaxis, all the patient with the VTE should be treated for at least 3 months. Different cases, like if the patient has first episode of VTE, secondly two, or a transient or reversible risk factor, we use the treatment for 3 months. If first episode of unprovoked VT, at least 3 months, we can continue uh, more than 3 months if according to the risk benefit ratio. Similarly, the first episode of VTE with inherited or acquired thrombophilia, at least 3 months, we can continue for further 6 months or like that on the basis of the risk factor. In the cancer associated VT, we should have to treat at least 3 to 6 months. And here in the cancer VT, the low molecular weight heparin, rivaroxaban or oxaban are recommended over the other anticoagulation. Secondary VT, so we will use indefinite period for that. Similarly, the treatment for cancer associated VT, the low molecular weight heparin is preferred as compared to the other direct oral anticoagulation. The deltaprin has the FDA specific approval for the cancer associated VTE. In the CLOT trial, deltaprin 200 units per kg as initial dose and then followed by 150 mg unit per kg per day or warfarin for 6 months. So in CLOT trial, the Debicatron shows better result than the warfarin. There is a case for the patient. RS is a 48-year-old man, height and weight is given, who present to the emergency department with pain, swelling in the left leg. On examination, his leg is warm to touch and tender and has 3 plus splitting edema below the knee. His D dimer is positive. His duplex ultrasonography identified a femoral popliteal DVT. He understands that he will need to receive anticoagulant therapy but want to avoid any injection if possible. He has good insurance coverage. His other medical conditions are hypertension, HIV, dyslipidemia. His medication include benzapril, ritonavir, darunavir, emtricitabine, tenofovir, atorvastatin. His vital signs are stable. Creatinine clearance is given. So we have to check which is the most appropriate anticoagulant regime to initiate for RS. So they gave these 4 options. If you will see that the option B, adoxaban, we know that the adoxaban is used in the changing therapy. In changing therapy, we start with the injectable anticoagulation and then we start after 5 days we discontinue the injectables and start with the adoxaban. But here they start directly with the adoxaban, so it means this option is not correct. Similarly, warfarin is used as a bridging therapy. Here they give the option of start the warfarin initially without bridging therapy. So this means the option is also not correct. Here the rivaroxaban Option A, 15 milligram twice daily for 21 days, and then followed by the 20 milligram once daily. This is actually a standard therapy for the treatment of DVT. But if you will see that the patient has hypertension and patient is uh, HIV positive, and the patient is using different HIV drugs like ritonavir. So these ritonavir is a protease inhibitor that is a potent inhibitor of cytochrome P450. So we know that if the rivaroxaban is contraindicated with the cytochrome P450 inhibitor or inducer. So it means that this one is the rivaroxaban will not be the correct option for this patient. So the remaining option is abixaban. As we know that the abixaban standard therapy is 10 milligram twice daily, and then we change to 5 milligram twice daily. But here they gave the option of 5 milligram twice daily for 7 days, and then followed by 2.5 milligram twice daily. This is correct because the patient is using the cytochrome P450 inhibitor. In that case, we have to reduce the abixaban dose as they reduce here 5 milligram twice daily instead of 10 milligram twice daily. So answer D is option D is correct option for this patient. So next is the reversal of anticoagulation. In the reversal, first of all, we have different blood products. Like these blood products are actually not used specifically for the reversal. They are mainly used for the management of the major bleeding, like packed blood cells, platelets, fresh frozen plasma, prothrombin complex concentrate, cryoprecipitate, and recombinant activated factor 7. Massive transfusion protocol. This is a protocol actually also for the management of the bleeding. When we this protocol is activated when there are 30 to 40% of blood volume is lost. 10 units of packed blood cells used in 24 hours. Transfuse entire blood in 24 hours. 50% blood volume in 3 hours, or 4 units of packed blood cell in 4 hours, and we know that we have to need it more. So in that scenario we have to activate the massive transfusion protocol. There are various different components are packed blood cells, platelets, fresh frozen plasma at a ratio of 1 to 1. They provide a hematocrit value of 29%, platelets of 88,000, clotting factor activity of 62% of the normal, and may need to provide periodic unit of cryoprecipitate sometime in this massive transfusion protocol. There are different issues with that is that thrombocytopenia, hypocalcemia, hyperkalemia, and acidosis. We also have to consider these things while using the massive transfusion protocol. Next is the unfractionated heparin. Protamine is the antidote for the unfractionated heparin. The dosing strategy is that 1 milligram of protamine neutralize 100 units of heparin. In patient receiving an intravenous unfractionated heparin, how we will calculate the previous 3 hours of the heparin dose, like, and the total dose of the past hour, the one half of the previous hour, and one fourth of the hour before that. Like for example, the patient was using 100 units per hour, so it means the last hour patient used 100 units. Then in the previous hour the patient used 50 units. Then before that the patient used one fourth. We will take one fourth, 25 units. So it means the total patient used 175 units. So we know that the 1 milligram of protamine utilize 100 units of heparin. So it means the in last 3 hours we calculate the units as 100% in the last hour, 50% of the previous hour, and one fourth of the previous of that hour. So we add all these and then calculate how many milligram of the protamine is needed to utilize 175 units of unfractionated heparin. Sorry, we'll just remove this one. And next is the maximum dose for any patient as a single dose should not more than 50 milligram of protamine. Low molecular weight happens. Similarly, the protamine is the antidote. 1 milligram of protamine utilizes 100 units of low molecular weight heparin, and for enoxaparin, 1 milligram protamine utilizes 1 milligram of enoxaparin. If the dose of the low molecular weight was given within the 8 hours of the reversal, so we will use the standard dose 1 milligram to neutralize the 1 milligram of enoxaparin, but we can repeat the half of the dose if we need it. On the other hand, if the last dose of the low molecular weight heparin patient took 8 hours before the reversal, we use zero point 0.5 milligram of protamine for every 100 units instead of 1 milligram of the protamine for 100 units. We use half of the dose of protamine, zero point 0.5 milligram of protamine for each 100 units. For warfarin, we are using the vitamin K. Vitamin K, different routes have different timing for to utilize the INR. For example, if we use the oral route, it will take 24 to 48 hours to utilize. If we use the intravenous route, it will take 8 to 12 hours. Subcutaneous route, actually it's not used because it's the vitamin K is a water soluble vitamin, so its absorption is erratic in that through that route. The fresh frozen plasma and 4 prothrombin complex concentrate are also used as a for the reversal of anticoagulation. The comparison between them is the 4 PCC provide faster reversal as compared to the FFP. Similarly, we need less units for the 4 PCC as compared to the FFP, and also it doesn't do not need to thaw, but for the other fresh frozen plasma we have to thaw it, we have to normalize the temperature before using it. The dosing units for FPCC, if the INR is 2 or less than 4, we use 25 units per kg. Similarly, 4 to 6, 35 units per kg, and more than 6, 50 units per kg. This is a flow chart which explain how different routes of vitamin K and the different doses of vitamin K we have to use in different scenario. Like if the patient has the sign and symptoms of bleeding and we need the urgent reversal, if yes, then we will start with the vitamin K 10 mg by slow infusion, and we can add 4 PCC if we need. Check the INR after 12 hours and repeat the vitamin K if we need it. If we don't need the immediate reversal and the sign of bleeding is not there, then we check the INR values. If the INR is less than 4.5, we omit the doses of the warfarin, check the INR in 3 to 7 days and restart the warfarin at a reduced dose. If the INR value is between 4.5 to 10, similarly we check here the bleeding risk factor. If the bleeding risk factor are absent, we continue with this strategy. If the bleeding risk factors were present, we continue with this strategy, and similarly if the INR value is more than 10, we have to omit 1 to 3 doses of the warfarin and administer 5 mg orally. of vitamin K or 1 to 3 mg by slow intravenous infusion. Check the INR after 12 to 24 hours. If the INR value is more than 9, then repeat the administration and then again check after 24 hours. Restart the warfarin at a reduced dose. Debicatron, now we will see the reversal of the direct oral anticoagulation. For Debicatron, activated prothrombin complex concentrate at a dose of 25 to 50 units. It normalized thrombin time within 30 minutes. But a specific antidote for the Debicatron is adalasuzumab. This is a fully humanized monoclonal antibody that has the affinity with the Debicatron is 350-fold higher than the Debicatron affinity with the thrombin. So it combined with the Debicatron remove it from the circulation. In the reverse AD trial, they evaluated two different patient population. One patient mm, who took the Debicatron and they have uncontrolled bleeding, and in the other population, the patient has to go for surgery and they need the urgent reversal. For both the patient population, they give 5 gram of adalasuzumab and they check that maximum percentage of reversal within 4 hours of the administration of the adalasuzumab, and they achieve 100% reversal in both the groups. Full reversal is occurred within 15 minutes and remained up till 12 to 24 hours. Next is the DEC10A inhibitors. DEC10A inhibitor also they use the activated PCC at a dose of 25 to 50 units. It reverses the anticoagulation within 30 minutes. There are the three different trials. In one trial, the patient received rivaroxaban 20 milligram twice daily, 2.5 day, and they administered the 4 PCC 50 units per kg, and within 15 minutes the prothrombin time returned to the normal. Similarly, in another trial, they compare the 4 PCC and 3 PCC. They check that the 4 PCC has faster reversal than 3 PCC. In third trial, they shows that the PCC could reduce bleeding volume and duration from punch biopsy within 4 PCC in subjects who receive a single dose of edoxapan 60 milligram. And the patient, they in this these patients they administer the 4 PCC at dose of 50 units per kg. And dexanet is alpha is actually the antidote for the direct oral anticoagulation. It is used as a bolus dose and then a continuous infusion for 2 hours. The reversal is achieved within minutes of the bolus dose and then it's continued during the whole infusion and 2 hours after the infusion. In Annexa 4 trial, they observed that 89% patient receiving rivaroxaban and 93% patient receiving abixaban, they achieved the reversal. If you will see, the standard dose is 400 milligram intravenous bolus followed by the 4 milligram per minute infusion for 2 hours. If the patient use 5 milligram of abixaban and 10 milligram of rivaroxaban or less, or patient use rivaroxaban 15 to 20 milligram but at least 8 hours has been passed. If on the other hand the dose should be bolus dose is doubled to 800 milligram and continuous infusion should be 8 milligram per minute for 2 hours. If the dose of the abixaban is doubled like 10 milligram or rivaroxaban 15 to 20 milligram and the taken within the 8 hour of the reversal, so we have to double the dose. For adoxaban, betrixaban, enoxaban, and fondaparinux, up till now there is no standard antidote for these drugs. Preoperative direct oral anticoagulation management. If we are using the Debicatron and patient want to go for some surgical procedure, we have to stop the Debicatron. If the patient has creatinine values more than 50, we have to stop it 1 to 2 days before the procedure day. If between 15 to 50, then 3 to 5 days before procedure. Similarly, if the patient is using ABIGAIL, rivaroxaban, and edoxaban, and the patient was going for minor procedure, we stop the ABIGAIL, rivaroxaban, or edoxaban 1 day before. If minor procedure but creatinine clearance is less than 30, we stop 2 days before. If major vascular procedure, we stop 2 days before. Next are the two cases. KD is a 49-year-old man, height, weight is given, who was given a diagnosis of an idiopathic DVT 3 weeks ago. He currently takes warfarin 8 milligram daily. He missed his INR reading last week when he went on a short vacation. Today his INR is 10.4. He is not currently bleeding and has no risk factor for bleeding. Holding his warfarin dose, which is the best initial strategy for managing KT high and INR. So the KD high INR is today is 10.4. So but he doesn't have any bleeding risk or bleeding sign and symptoms. So it means we don't need any urgent reversal. So option D and option B is not correct, because both these options are used in the immediate reversal scenario. Next, if the INR is more than 10, what is the strategy? We have to stop the INR or stop the warfarin 1 to 3 doses and give either 5 milligram of oral vitamin K or 1 to 3 milligram of slow intravenous infusion. So it means this option is wrong. This option is correct because they are, here they give the option of give vitamin K 5 milligram orally. So option C is correct. JW is 58-year-old man receiving enoxaparin 40 milligrams subcutaneous daily for VTE prophylaxis. While trying to shave himself at 6 p.m., he cut his neck and the medical team cannot stop the bleeding. His last enoxaparin dose was given at 8 a.m., which would be the most appropriate protamine dose for JW. So the patient was using 40 milligram of enoxaparin. We have to reverse that one, as we know that 1 milligram of protamine neutralizes the 1 milligram of enoxaparin. But if we will see that the patient used the enoxaparin at 8 a.m. in the morning and the patient has a cut at 6 p.m. So it means after 14 hours of the last dose. After 8 a.m. and 6 p.m. At 10 hours of the last dose. So in that case, the more than 8 hour has been passed. If the more than 8 hour has been passed, so we use half the dose of the protamine to neutralize the enoxaparin. Like here we use 0.5 milligram of the protamine to neutralize 1 milligram of the enoxaparin. So instead of using 40 milligram of protamine, we used 20 milligram of protamine. So answer B is correct in this for this patient. So this is the end of the presentation, and thanks for your attention. If you have any question, you can send to Dr. Kamran. I will answer any of your question, inshallah. Thank you. Allah Hafiz. Assalam.